Okay. Mallory, I'm so excited to be talking with you. This has been in the making for a while. So thank you so much for being here.
Thank you for having me.
Wonderful. So welcome to everybody. This is we're trying to get back to our monthly webinar series. Today, Mallory and I are going to be talking about understanding ARFID and supporting caregivers. So Mallory's using one of our accounts. So she's not Jody, she's actually Mallory, but on we go. So as people are sort of filtering in, I know we've got a number of people registered. We are recording this event so that if people want to watch it later or couldn't make it today, they can join us later. Mallory, you and I started having a conversation sort of online months ago, didn't we?
Yes, yeah, it was a long time ago.
It was a long time ago. And we were having this conversation about your own experience, as a mom, as a parent with a young child with ARFID. And I was so struck by the things that you and I were talking about. And I remember saying to you, we need to put this in a webinar. We need to just have a conversation, the same conversation you and I were having, but I really wanted it to be, I think we both wanted it to be something that was more publicly available, huh? Yeah.
Yes. Yeah.
Okay. So that's what we're doing. The nature of these webinars is not particularly super formal. I want them to be reflections of the kinds of conversations that we've had. And so that's what you and I are going to try to recreate today.
Yes.
Fair? Okay.
Yep.
So to those watching, I have a few slides because I thought what we would do is talk a little bit more formally about what is ARFID, what do we know about ARFID. But I really want to spend the majority of time, Mallory, talking to you and your experience with this particular illness, because it really isn't, we don't talk enough about this.
No, not at all.
No, it's actually incredibly hard. And one of the things that's been happening in our clinic and probably everywhere is that we've been sort of inundated with parents calling with very young kids with what might be ARFID, or they'd like an assessment. And it's very hard to get them in anywhere where it's either publicly funded or where people have the assessment or training in this particular illness. So I'm so glad that we get to do this together.
Yes,
today.
me too. Yeah.
Okay. So should we go? Should we get started?
Yeah, let's do it.
All right. All right. So I'm not going to spend a lot of time here. What I want people to know is that ARFID stands for avoidance and restrictive food intake disorder. It is a type of eating disorder. And as you're going to hear us talk about today, it's not just picky eating. It goes well beyond that. It was something that was studied for many years, actually, in the eating disorders field. But like anything, there needs to be enough research, enough evidence to understand, is this its own illness? How does it work? What do we know about it? And so in 2013, ARFID was formally introduced as a diagnostic entity in the DSM, so where we as psychologists, psychiatrists, and others diagnose from. So it's been around since 2013, but here we are in 2023, right, Mallory? Like 10 years later, yeah. And you're going to speak to this more than I will, but even though it's been listed as a diagnosis for 10 years, treatment, accessibility, knowledge about this is sorely lacking. It's pretty astounding.
Yeah.
Okay. So what are these diagnostic criteria? Well, the first thing to know is that ARFID, as we said, is a feeding disorder characterized by a pattern of highly restricted intake. So these patterns usually develop in childhood, and either you're seeing difficulty in quantity, so failure to meet enough energy needs, or just not eating enough food, and or difficulty with variety. So kids that simply are unable to eat a wide enough variety of food, and it starts to impact on their nutritional needs. They can have both or one or the other. Sometimes parents will say to me, but how do I know my kids are picky eaters? Because picky eating's a fairly normative thing as well, right? People go through phases and stages. We know that it's an eating disorder when the pattern of eating leads to weight loss or failure to achieve expected weight gain in a developing and growing child and youth, if it's leading to nutritional deficiencies, if there's a dependence on other feeding, oral nutritional supplements, so that the kids simply can't eat unless there is tube feeding or some sort of supplementation, and or there's marked interference with their functioning. It's getting in the way of school, relationships. They can't go to birthday parties. There's a lot of anxiety. They're just not able to live sort of a normal, carefree life because of what's happening. Mallory, I'm noticing you nodding. Did you notice some of this in your, do you want to say a little bit here maybe about what you noticed?
Pretty much all of them.
Oh, really?
Yeah.
Like right away, or did it develop over time? Can you say a bit about?
It developed over time, and a lot of it is now, like, now that we know, looking back on things, and kind of seeing those little flags that were there.
Yeah, it's always easier, right, to look back and go, okay, right? But it's hard to know when you're in it. You know, is this a problem? Should I do something? Yeah. Okay. And Mallory, I know we've talked on and off over the months. Do you want me to ask you questions as I go like this?
Sure.
I'm informal like this, or would you rather just tell your story?
No, I'm glad to do it this way. So yeah.
This is how we've done it in our private meetings. Okay, so I'm going to keep going. So you noticed all of these things. Okay.
Yeah.
Okay. We want to highlight that ARFID is different than other eating disorders in several key ways. One is that people that have ARFID, they're not concerned with body image, weight gain. They're not preoccupied with losing weight in the way that somebody with anorexia might be, or bulimia, or other eating disorders. The focus here is really about how the person eats. And we're going to talk about the types of ARFID presentations that you might see. This is not the result of food insecurity or a lack of available food. That would not be considered ARFID. It's not a culturally sanctioned practice. So it's very important for me when I'm assessing, or for my colleagues, to make sure that, you know, that what we're seeing isn't part of sort of normal cultural practices. And it's not explained by another medical or mental illness. So again, when you're meeting people that might have an eating disorder, especially ARFID, you're trying to understand what else might be going on that might account for, or better account for, what you're seeing. I can tell you it's complicated for the reasons that we're going to discuss. So Mallory, as I go through these, I'm wondering whether one or more relate in your experience. So there's three predominant types of ARFID presentations. One is that the child, or even the adult, because a lot of people that we're seeing were never diagnosed as kids, and now they're adults with ARFID. So, you know, so we can see this across the spectrum. So they find new foods, they have strange tastes or textures or smells. They really have trouble with the texture of food, sometimes the color of food, or the intensity of the smells or tastes. So they have this really sort of significant reaction and don't like to eat, especially variety, when this is happening. The second presentation is that others have had a scary experience with food, like they've had a choking experience or an allergic reaction. So food becomes more frightening. So they become afraid that they're going to choke again, or they're afraid that they're going to have another allergic reaction. And so they start to avoid eating foods that are chewy, let's say, or foods that have particular similarities to what they're afraid of. And so they really start to limit what they're eating. There's a third presentation, again, where others simply don't feel hungry very often. There's a biology to this, but there are a subgroup of folks who just simply don't notice the same hunger and fullness cues. They find eating to be quite boring, like a chore. They might even feel full very quickly. So there may be something different in the way that both their metabolism and different brain regions are working, so that food is not a very rewarding experience. And then, of course, having ARFID then reinforces all three of these domains. So Mallory, I'm wondering, did you notice, one of these, all of these, how did things sort of play out in your family?
I would say number one, it was a lot of sensory stuff, I think, that we noticed first with him.
Okay.
And then it's number two also applies, but that one's more new, but it's become kind of another reason to avoid certain foods.
Okay.
And it became like very surrounded of fear of throwing up.
Yeah.
Yeah.
Which developed after. So it first started
Yes.
more with the textures and
Yeah.
and things like that.
And
Sensory.
he's still got that one. Like, he definitely has a texture preference when it comes to his foods. So
Yeah.
that one still hangs around too.
Yeah. Yeah. I think that's what I've noticed that as well. And again, I still feel like I'm learning when it comes to ARFID. I just want to be really transparent about that. You know, there's a lot to learn, and the literature keeps evolving in terms of how we understand what ARFID is. And so it's not uncommon to see more than one presentation at the same time, right? Yeah. Yeah. Did you notice at all in your son whether he had trouble with feeling hungry or full? Was there anything like that?
I would say so, yes. I find that it'll take him a very long time to actually say, hey, I'm hungry. He doesn't eat snacks. Like, he only eats breakfast, lunch, and dinner. So there's nothing in between. And if I do offer that, he will normally turn me down for that. So
How did you first know that there was a problem? Like, at what point? Because a lot of parents sitting here watching may say, well, my kids go through this. Like, how did you first think, I think there's something more going on here?
so up until about 12 months, he would eat everything and anything. And then between a year and a half, he started to really drop a lot of foods, and he wouldn't accept anything new until we were at the point of only having a very, very small list of safe foods. And when I would bring it up with like healthcare professionals that we would see just in regular appointments, it was just kind of, oh, like, toddlers become picky, and it's okay. He will get through it. But it wasn't until we had a separate health thing happen. He ended up waking up one morning and having really, really low blood sugar. And it was at that point that we found out that his sugar was low, probably from poor intake. So that kind of triggered me to be like, we need to have some extra help. And I reached out to early intervention services because I think he was about 2.5 at that point. And we got a little bit of feeding help, but we still never had the ARFID diagnosis at that point.
Did anyone talk to you about ARFID at that early stage, or it wasn't
No.
even on your radar? Or
No.
okay.
It became like we knew that there were some sensory things that were happening as well, not just surrounding food. And in the early intervention intake, there was some red flags for autism that were also brought up. So that thankfully opened up a bunch of other services for us. So when we accessed those, the autism diagnosis journey kind of took over from the feeding. And if I would bring up, hey, like, we're still really having a hard time with his feeding, not really sure what to do, we would get some like sensory activities to do at home, try to desensitize his face, or like do some really heavy work things just to kind of like bring his body down so he could accept some new foods. Those never really seemed to work for him. So we just kind of carried on. With just kind of hoping that we would find the thing that would help him.
We're going to talk about the overlap with autism and other, other struggles, illnesses, et cetera, that tend to co-occur with ARFID in just a few minutes. But I think that that's such a common experience of, especially when they're young, sort of, and most people aren't trained in eating disorders, let alone ARFID. So I think, many people who might think that there's something going on end up going to their pediatrician or going to their doctors, who kind of reassures them that everything's fine. They're not really aware that there actually could be something much more serious going on.
Yeah.
And we all know that early intervention is ideal, right? So the earlier we can, it's one of the reasons why we're doing webinars like this, is to try to promote and to help families advocate for themselves, but also to help those in healthcare to become more aware of what ARFID is.
Yeah.
Okay. So let me move to my next slide, which is to highlight, that ARFID isn't a choice, right? There is no choice about this. And this is one of those stigmas that follows all eating disorders, right? Is that they're a choice, that if somebody could just, if they could just turn their mind toward change, they could just eat and it would all be better. But that's not what eating disorders are at all. And there's very specific neurobiological, genetic, metabolic factors that play into why people develop eating disorders. These are significant illnesses. And really, really important that we appreciate that. You can't just sit at the table with your son, for example, and say, listen, I need you to just eat.
Yeah.
That's not going to happen. And it's interesting that you say too, that even with the autism sensory interventions, right, that those also didn't work, right?
Yeah.
Which is what we're finding, is that if you come at it just from the autism spectrum lens, that can be helpful with some of it, and it's not enough. You have to also come at it from the understanding what eating disorders are.
Yes.
Right. It's sort of, and that's what we're going to talk about. Some of the protocols for treating ARFID are this blend, right, of understanding sensory, but also understanding eating disorders. And so here's this slide, right, which you've already highlighted. And Mallory, I'd like you to speak to some of these other pieces. I know you and I have talked about some of these things. We know that many people that have ARFID have co-occurring disorders. Some have autism spectrum, as you're talking about in your particular experience, but not all do. So it's not that ARFID is part of ASD. It's not. We just know that there's overlap. We also know that there's a higher percentage of kiddos and adults with ARFID that also have obsessive compulsive disorder. Yep. Mallory, yes, yes. Okay, now what are you're giving me the big head nod there, Mallory. So what are you thinking when I say OCD?
That one's a newer one for us, and that goes with the throwing up. That one, it was the last couple years that kind of came to light for us.
Can you say a bit more how that, like what ended up happening there?
He got just a normal stomach bug, I think, and it freaked him out so much. He connected it with food. He also has a dairy allergy.
Okay.
So with that same time that all this was happening, with the stomach bug from school, I'm not sure if he thinks that he consumed dairy or if something just made him sick, but it kind of all blew up at once, that food just became very scary for him. And a lot of the, what if it's contaminated? What if I throw up? And it really took over his life for a little bit. And of course it had to just center around food.
Well, and it's not, again, it's not uncommon to see these, and it's interesting to notice the evolution.
Yes.
Right. That's sort of, starting with the textures and sensory issues and fear of, and then evolving into sort of a fear of, being sick. And it's really interesting because some of the newest data on ARFID does show that these are usually kiddos that have a history of gastrointestinal problems or a more sensitive GI tract, or, there's some other medical or allergies. We also are seeing more in terms of food allergies. And it makes you, again, we don't know enough yet, but it makes you wonder about, even from a genetic, biological perspective, is there something that's more sensitive so that they experience eating and food and digestion very differently than people who don't have this particular wiring? Does that sort of make sense? Yeah.
Yeah, definitely.
Right? Very, so we see, even ADHD, anxiety disorders, very common. One of the things that's always caught my attention too is that a lot of people, well, with eating disorders, but particularly with ARFID, have oral sensitivities. we didn't know this a long time ago, but this idea that food is actually experienced differently, even in the mouth, even in the way that you taste food. You sort of take it for granted that eating, tastes a certain way and feels a certain way. I don't think it does for people that struggle with oral sensitivities. I do think that those textures make a big difference. And it's interesting because there's an evolutionary function to food preferences, right? Like if you go back in time, even the disgust response, right? Like, is actually designed to protect us from eating potentially contaminated or rotten food so that we live, right? So it's kind of interesting. It's almost an overactive or a system that never really shut down.
Yeah.
To still be sort of perseverative around, am I safe around food, and food is dangerous, and an overactive, even disgust response. And so you're noticing that that's kind of making sense to you?
Yeah. Yeah.
Okay.
Yeah.
Anything, you want to say here? Yeah.
Things like candy for him, for example, like he doesn't like candy, but it's too sweet. It's very intense for him.
See, that's so interesting.
He likes salty though. So
but taste is experienced so differently. This is, when we treat people that have eating disorders, back in the day, it was, look, you come into treatment, you feed everybody the same way. Everything's considered the eating disorder, and you just got to expose people. There's still some truth to that, like, because the eating disorder will have you avoid everything or most things. So you have to face some of your fears, except that there's greater knowledge now that, it's important to be able to be sensitive to the fact that different people are going to need to eat differently, or need, more consideration about how you're feeding them and how taste is experienced. So, and the sensation of taste is very complex. So it may be that things that are sweet are too sweet, but salt is okay. Like it's fascinating. I love reading every new paper that comes out because I learn something new all the time. So does he have other preferences with taste that you've noticed?
No. A lot of his textures are the same, like they're crunchy.
He's okay with crunchy or doesn't like crunchy?
He's okay with crunchy.
Okay.
Yeah.
Yeah.
Yeah. And then very, very few sweet things. Like he will tolerate some, but for the most of them, it's just a reaction of, this is way too sweet. And you can even see it on his face if you can get him to try it. Yeah.
Yeah. So he processes it differently, right? Like the way that he experiences that. And I think historically, I think we've tended to overlook, though not overlook, but not consider them when we're trying to feed people and help people learn to eat, and I often ask, my clients or family members, imagine having to eat something that you find disgusting, or that really, really bothers you from a taste or texture perspective. Like imagine having to do that then multiple times a day.
Yeah.
Like how hard that would be.
Yeah.
And again, driving home that point that there's no choice here. Like your son didn't choose to eat this way. It's part of this is how he is in the world and how he's coping with the way that he works. Yeah.
Yep. Yeah.
Okay. Now, Mallory, I'm jumping a little bit here to what happens to caregivers, because this is so serious, and a lot of the kiddos get very, very sick. They can't eat. They're losing a lot of weight. They end up in hospital-based programs if they can get in. I know sometimes we've had calls for kids as young as 5 and 6 years old, and there's very few places that will take them at that age.
Yeah.
Very, very scary. When you've got a kiddo that just can't eat, and you're watching them get sick. I wonder what the impact on you and your family has been. These are some of the key things that have been highlighted in the literature.
All of them fit, especially in the time that we did not have diagnosis and we were just trying to figure out what was going on.
Yeah.
There was a lot of feeling unseen and feeling misunderstood. Because anytime I tried to reach out, even to like another parent, just to say this is what's going on, no one understood, or no one seemed to get how hard or how serious it really was.
Yeah.
And the stress, definitely, because I would be so hopeful that I bought like a pack of 100 cookie cutters from Amazon, thinking that maybe if I cut his food into fun shapes, that will be what it is. Maybe,
Yeah.
and then it's so easy to have it turn around that maybe I'm not doing a good enough job. Maybe I'm missing something.
Yeah.
Um,
That's
and then
awful.
just, yeah, just to
That's
have
awful.
him and not know why at that point, but to have him flat out refuse anything.
Yeah.
Yeah, and then there was also a fear that if I would take him to a doctor's appointment and if he hadn't grown enough, that I was going to get in trouble as a parent.
Yeah.
That,
No, I think this is, I've heard this quite a few times, right? This, again, the sense of I'm doing something wrong.
yes,
I'm not feeding my child properly. I'm to
yeah,
blame.
yeah,
What an awful feeling.
yeah. And then he was still young at this point, so we didn't really have like a much of the social stuff like with the birthday parties at that point.
Right.
But even going to friends or family's house for dinner, and
Yeah.
he would
Yes.
really struggle kind of being around the different foods, the different smells, so much that he almost couldn't like regulate himself. So if there was one thing that would set him off, it would be a really big blow up.
Yeah.
And we didn't know why, but it just makes so much sense now.
Yeah. I'm so glad you brought up that emotion regulation kind of piece. It's sometimes, you think, oh, why are they so upset? Or why are they, this is so, because it's so hardwired, because it's how they, how food is experienced. When you're in a setting where you are not comfortable, where you don't feel safe, even as a child, where you can't even express that, it's very common to see them upset, to see them emotionally dysregulated, or to even get into other behaviors that can, be self-harming of nature, just because they can't cope.
Yeah.
They can't, and it's awful to be in an environment where other people don't understand. There's this kind of, especially with kids, oh, just eat this. Oh, you're being difficult. Oh, and
Yeah.
it's so not that at all.
Yeah.
And yet as a parent, it must have felt, well, I don't know. It must have just felt scary. Yeah, just really anxiety provoking to sort of not
Yes.
know how to help.
Yes.
And yet you're not getting any real help from the medical field, right? Like,
Yes. Yeah. We're in a very big gray area at that point. And even like the fear of judgment from other parents, because
yeah,
why
yeah,
is he just eating crackers for dinner?
right,
And
right,
then yeah,
right.
should are we giving in to him? Does he have control over us?
Right. No,
So,
no, but I think this is what there's assumptions too that the parents aren't working hard enough, or
yeah.
they're too easy on the kids, and and I've sat with enough parents to know that, oh my gosh, like when you just talked about the 100 cookie cutters,
Yeah.
I thought that was such a great story of just how desperate parents are. They've tried everything.
Yeah.
And
Yeah.
often it is the case. I remember somebody calling, and as I do, I say, you've got to go back to your pediatrician. You need to, because that at least can open the door to other referrals. And this family went back to the doctor, and the doctor just said, this is not an eating disorder. This is just a kid being a kid. And the parent called and was just in tears, and it's just heartbreaking what parents what they go through
Yeah.
trying to figure this out. And I'm so glad that's why, that we're having this conversation
Yeah, me
today.
too. Yeah.
Yeah. Yeah. How did you get support? Like, I'm sitting here thinking about all you went through. I mean, how did you manage?
I don't know.
It's
I
just,
have no idea. Going back through everything actually brought up a lot of emotion for me, just to like,
I bet.
holy,
I
that was
bet.
a lot that we were going through, and I didn't even really realize it at the time, just how tough stuff was.
Are there other examples, like when you were reviewing sort of your, I don't know, your notes for this, or are there
Um,
things that we haven't talked about?
One of the things that it was kind of like almost funny, the specialist for his blood sugar, we saw so many different people over the course of this, but one of the most simple ways to treat the type of hypoglycemia that he had was to give cornstarch at nighttime. So cornstarch is like a slow burning carb, I guess. So it would hopefully help, because his drops are usually overnight in the mornings. It would hopefully help like him stay level throughout the night. And it's just such a simple thing that, you just give him some cornstarch, either in some water or some juice. And it's amazing if that can work, because it's cheap and easy and readily available. But I had to sit and tell the specialist that, he won't eat that. And we cannot, he drinks a juice, and it's one of the more nutritional things that he has. We can't sacrifice
that's right.
him rejecting that now because we're trying to put cornstarch into it.
And given his taste, I don't know, his taste buds or his I don't know, overactive, I don't know. If you even try to put the corns, he would know immediately, right? And then all of a sudden, then that one food item that is safe becomes unsafe.
Yeah.
And it's also a trust issue. This is what's complicated, right? Because now if you're trying to sneak things in, they're already so afraid. That it's complicated. It's so complicated, isn't it?
Yes.
I so appreciate that. Yeah.
It starts that conversation with a doctor of, okay, but what about pudding then? Can we try pudding? And it's just, I always left feeling so almost guilty that I had to be like, no, that won't work. No, this won't work. They probably think I'm very difficult, but like, we've tried so many things.
Yeah.
I
think that you're right. I think a lot of parents leave appointments feeling like blamed, or that they're just not working hard enough. And and that's, it's awful, because, those of us in the eating disorders world know that it's not, you can't, feeding people is so difficult. And here we're talking specifically about ARFID, but across the eating disorders, it's one of the reasons why we look for those integrated approaches, right? Because sometimes people say, well, let's not talk about feeding him. Let's talk about, and I say, but you have to help him learn to eat. Otherwise he won't eat by his own nature. Oh my gosh, that's significant. Let me just hang on. I'm just going to push us here a little further, because what I'm curious about, Mallory, is whether you've seen this. I'm sure you have, which is that there's the underlying vulnerability. In eating disorders, we always say genes load the gun, the environment pulls the trigger, right? So stressors and things like that. And with ARFID, we're still learning. We're still trying to figure out how it all works. But we do know that if you have that biological vulnerability to develop ARFID, let's say, then eating a certain way also reinforces the biological vulnerability. It's like you're on a hamster wheel. So, for example, eating the same foods all the time makes new foods taste even more unusual.
Yes. Yep.
Right. And anybody that's ever done this, you ever change the way that you eat a little bit, and you notice how hard it is at first, and then once you're used to, it can be very difficult to introduce new foods.
Yes.
Nutritional deficiencies also change taste perception. So if now you're low in vitamins or minerals, we know that can also change the way you experience taste. So again, it makes it difficult to eat. We certainly know that avoidance of any kind, across the disorders, avoidance makes it even harder, right? The more you avoid, the harder it is to actually face things. And this is the conundrum, right? How hard do you push versus, boredom when eating leads to eating less. So for some of those kiddos that, if they're bored when they're eating, this can actually perpetuate this. And all of this reduces the amount that one is able to actually eat, which leads to weight loss and other health problems. And I'm watching you nod again, Mallory. Do you see this? Are there patterns like this in your son as well?
Yeah. A lot of them. I find we've accommodated a lot of things for him too, to make him eat. And the boredom when eating. So we're in a very bad habit of he eats with his tablet, because it was the only way that he would eat sometimes. And now without it, he's bored and he will just sit there. He will not eat.
Actually, it's so interesting because you're like colloquially, like we all, oh, don't eat with your tablets, don't distract when you eat. And we know that sometimes if that's the way to get somebody to eat, distraction or keeping them, that can be the effective thing to do, especially when they're really young.
Yeah.
So it's not uncommon, but it's interesting. As you said it, there was almost like this, like, oh, I shouldn't do that. And I just think, oh my gosh, if that's going to help him eat, that's great. Because, some of them just find the whole act of eating just very non-rewarding. And they just won't, they'll be very slow, very, very slow eaters. And for some of them, without the distraction of the tablet, the texture, the taste, that's all they're focusing on.
Yeah. Yeah.
So if you're already predisposed to being sensitive to those things, and now it's a quiet dinner talk, like it can be incredibly difficult for people to eat in those circumstances.
Yeah.
Yeah.
Yeah. And the first point about eating the foods, the same foods, he's so that kiddo. Yeah. Even if we've tried to change up brands of, like he likes veggie thins. We try to buy the PC brand veggie thins, and he knows.
Yes.
Like there's a huge difference to him where to
it's
you
amazing.
or I there may not be. Like
it's really uncanny when you sit with somebody with ARFID, how adept they are at detecting incredibly small changes in texture, color, even, or like you said, even brands. So it's the same food, but it's a different brand. It really is remarkable. And to me, it really speaks to neurobiology more than anything. Again, you can't pick that about you. You can't say, well, I'm going to become very picky about my taste perception. It doesn't work that way, right? Right. And then again, so part of the treatments as they're currently being designed that we're going to just talk about next is, how do you help a child eat when this is what's going on? And the book here by Jennifer Thomas, Cameron Eddy, is one of the main books used. It's a CBT approach for ARFID across the lifespan. And, so I'm curious, before I even go into that and we talk about that, when did it change, or did it change in terms of your son's eating? Like, so you're talking about going through this period of time where nobody's really doing anything about it. You have the autism journey started, but this piece continues. Then you've got OCD on board. What happens?
So it was 2020, I believe, late 2020. We had just a routine pediatrician appointment just to kind of discuss everything that had been going on. And that is when the pediatrician said, like, hey, he's not really growing how he should. I don't know what more I can do on my side. I think it's time for a referral to sick kids for a feeding tube, which threw me for a loop because I had never, that wasn't even on my radar. So it was like, okay, like this is what we have to do. And I researched and I read and I really learned about the positives that a feeding tube could bring. And our appointment was in February 2021. My husband, my son, and I drove down there. We were ready to come home with an appointment for a feeding tube. And instead we did not. We came home with an ARFID diagnosis. And it was the weirdest experience because it was so full of emotion. Like we had absolutely no idea that this even existed. I'm sure I had read about it at some point, but no one had ever brought it up to me, and he just fit just perfectly. And they educated us on how this isn't his fault. He's not doing it on purpose. He's not doing this to be difficult. This is not something that we have done as parents. And that there are things that we can do to try to help. So yeah, that we've been followed by them. I didn't realize that there was the big medical piece of it with like blood work and stuff that
Yeah.
should also be managed.
Yeah.
So we had all of that done, and it just kind of brought us like up to where we probably should be. Um, and yeah, that's kind of how we are where we are now.
It's quite a roller coaster. And I, I know that not all hospitals have the type of training or resources that Sick Kids does. They've got different branches and so I'm so glad that you got there and they were able to sort of say, hold on a second, let's look at what's going on here. And it's been hard because the demand for services has been so high that people are waiting on waiting lists for very, very long periods of time, sometimes well over a year.
Yeah,
So that must have been quite shocking.
it was. Yeah,
Was it relieving? Like, was it yet another diagnosis to absorb? I mean,
it was kind of both,
yeah,
to be honest. Yeah. But it was nice to have something to help explain things
for sure,
to
right?
like our family. And school was, I kind of, I guess, missed that part. School was tricky when he started kindergarten. He just wasn't eating there.
Yeah, how did you manage that? Like, how did the school manage that?
We didn't really do anything.
Yeah,
um they knew that he had like eating troubles when he went in, but yeah, they would encourage him to try to eat, but he just wouldn't, and no one knew why, and we just kind of
yeah.
continued through.
Yeah, I think like most parents do, you're watching, you're waiting, you don't really know what it is. You don't know if it's a phase,
Yeah,
but you forget all the pieces like school, appointments, family, all these things where it just becomes more and more difficult
yeah.
to manage. Now, when you talked about blood work, I don't know if everybody here knows about, you and I go, oh yeah, of course, the blood work, but what did you learn about the medical side of things?
It was a whole like nutritional panel of blood work, so it checked his vitamins, his minerals.
Yep.
It was a lot.
Yeah.
But it did come back with some deficiencies. He was very, very low in vitamin D. Like
Yeah.
scary low.
Oh my goodness.
Um,
Yeah.
like I can't think of the name of what that is when it's really, really low, but it was close to that.
Okay.
So there was a few other things that were low. He is on a nutritional supplement that helps, but with Sick Kids and having the team, they know how much to up it to fill in the blanks.
Yeah.
We supplement with vitamin D now, like every
Yeah.
day.
Yeah.
I can't think of the other ones, but there were other ones. But
No,
we've
yeah.
I think a B vitamin was low, maybe too.
Okay.
But even just those few things that we made the change with, it changed his energy like huge.
Oh, for sure. I mean, B, especially, well, all of them. I mean, vitamin D, if you've got very low vitamin D, that wreaks havoc
Yeah,
in many, many ways. And,
yeah,
and it's interesting too. We've had situations where blood work comes back with low vitamin D. And again, there's this kind of, oh, you live in Ontario, it's the winter. I'm like, oh my goodness, like it's part of the eating disorder.
yeah,
It's not just living in a place where there's not a lot of sunlight for a period of time. And these are markers of the impact of restrictive eating, malnourishment. That's what it
yeah,
is. They can't
yep,
eat enough, right? It's very scary, but a lot of it, our bodies are tough in the sense that they can go long periods of time with, and you kind of go, you can't tell. It's not like it's not always the low blood sugar effect where it's
yep,
very clear something's going on until it's very, very serious. And so for all of our clients, we require quite extensive panels, and we would want families to be getting that information because you won't know otherwise.
yep. And
Yeah.
it also gives a little bit of feeling of control on like the parents' side as well, because at least we can manage that.
Yeah.
And that's covered a little bit better than it was before.
Every little bit. I mean, there's
Yeah.
nothing worse, I think, than being a parent and not knowing what's going on with your kiddo and not knowing how to help
Yeah.
and feeling really isolated in this journey, like not really, that's a terrible, horrifying experience. So any little bit of understanding what's going on and that there is actually treatment and there are things you can do is huge.
Mm-hmm.
And I mean, I just put this slide up here. This is from Jenny Thomas's book. It's not mine, but this is sort of what CBT for ARFID looks like. Again, it's much more complicated. There's a lot of psychoeducation. So Mallory, a lot of the things that you're talking about that you would have learned at Sick Kids and in reading about ARFID, there's a big part of educating parents, families about what is actually going on, both in terms of neurobiology and also just in terms of learning. So that's that first part, like what is going on and are there certain things you can do? I don't know if you did, I don't know exactly what treatments you're following. In this model, we do ask families to, keep track of what's going on, looking at, how much somebody's eating. Is there any way to sort of make small, very, very small changes? And then continually moving forward. But a lot of it's exposure work.
Mm-hmm.
A lot of it is very gradual, consistent exposure. And I'm curious, have you done any of this type of work, given how hard it is to feed your little guy?
Right now, the thing that we're working on, so we haven't found like consistent help, I guess. We've had little bits and pieces here, so we're just trying to piece it together on our own. Right now, the challenge that we're doing is 1 carrot on his plate 3 times a day.
I love that you sort of laugh when you say that, and I'm wondering why you're laughing.
Because until you're in it, it sounds very silly, I guess, but it's how to do it. It's slow. That's the one thing that I've heard consistently is like, this is going to be a slow, like, process. It is. And it's tough because there is very, very little reward on. You think that maybe you'll put a carrot down and on try number 3, he's going to try it. We've got a little nibble, and that's a huge celebration.
Yeah, it is
internally because
I know,
I'm right. Making a big deal.
Yeah, you don't want to make a big deal, right? I know. But see, there's even that, like, learning what is the parent's role, yes. Like how does the parent respond? And you're highlighting also a fair degree of patience and emotion regulation on the part of the parent. Yes. Like I can imagine being very emotional myself. We get tired, we get frustrated, we get scared.
Yeah.
And they're right. This is a very slow process. And I really appreciated your example of the carrot because it's exactly like that. It can be, sometimes it's just even smelling different smells and just getting exposed to the smells or, just even something on the tongue. And they can't eat it at first, but it's just exposure to, depending on exactly what goes on for a particular person, because it's always different, eh?
Yes. And with the carrot, he will pick it up, kind of like lick it or take a little nibble to make us happy, but then that's off his plate. Like it has to be off of his plate and kind of hidden behind something before he can eat the rest of his food.
Yeah.
Yeah.
Yeah. And I'm still learning myself more about how to treat, especially when there's OCD on board, autism on board, there's this, how far do you push? And I, as a DBT or dialectical behavior therapy, I'm always thinking like, where's that middle ground? I got, okay, so where's my little effort to push? Because, otherwise they do face a lot of health problems and psychological problems, right? Because malnutrition is malnutrition. Yeah. Right. There's a number of things you've got your story you've been saying. Yep. Mallory, these are a number of books that you and I looked at, like that we wanted to make available, that if people were saying, oh my gosh, she's talking about my family, this is what I'm going through. There are a couple of books here, 3 books actually, that people might want to look at. This will all be made available as well online. So and then there are a number of groups, and Mallory, I credit you, put these together for me. I didn't do this. And Mallory, can you say a bit about why you identify these groups, or how you find them helpful, I guess, that are...
I was just searching for other people like me. I'm not sure which of the Facebook ones, but one is for like caregivers of people with ARFID. I believe the Reddit group actually has adults that have ARFID as well. So it's been helpful for me to kind of read about people's firsthand experience with it. Because part of it is also, as much as I want my son to be able to enjoy and eat foods, I also want to accept him for the way that he is as well, and not try to like put him into this box, because I'm not sure at the end of the day what the goal is. Like, I don't know that there is a finish line that we will reach. So like working on accepting that part of him just for who he is too, but making sure that he's happy and healthy is really...
Well, I think, again, you bring up this, again, defining what does it mean to recover? Who defines that? What does it look like for people that have sensory differences, that have different, they experience the world differently, and I don't come from a one size fits all sort of mentality. And so I think that all of us are trying to make sure that people are healthy. Like, we don't want people to be medically unstable. We want them to be able to, have a quality of life, live their lives. And does it mean, I don't know. It's interesting that you say, what's the end goal? I don't know. Are they supposed to look like they eat like everybody else does? But then I say, what does that look like? Because we live in a culture of disordered eating. So I'm not really sure. So Mallory, we only have a little bit of time left. Are there other things that you would want families to know? Do other people listening to you right now that are maybe at the beginning of this journey, or is there anything else that you'd like to say?
I don't know. I'm stumped a little bit on that.
Yeah.
I really don't know.
That's okay.
Yeah.
You've offered so much in terms of, I mean, what I hear is sort of a persistence. I think that, unfortunately, I wish it was different. I wish that people could get the diagnosis right away and get treatment right away. And I think you and I both know that it's not likely to happen that way for many people. At least not yet. But I think your persistence is, I have a lot of respect for that. It takes a lot to keep going and to keep trying health professionals, and, keep turning over new stones and trying to figure out what's going on. And you've stayed in the game with your son and your family. And, that takes a lot of strength on your part to keep going when you feel alone. I think, Mallory, you and I talked a little bit about, we want parents and families to not feel so alone. Even if you can't get the answers from a doctor right now, or you're not sure, I mean, still connecting with Facebook groups, or, how can we sort of come together as a community and say, hey, you know what, you're not alone. This is difficult. And here are things that you can do. I will tell those watching the good news that I see in my work, and I'm speaking specifically about Ontario right now, although I think it's fair to say this is true internationally. More and more of our OHIP covered teams and private clinics are being intensively trained in ARFID. Part of the problem for many parents is that the hospitals didn't have the evidence base. They didn't feel like they were skilled to treat ARFID. So, you're not going to take on illnesses that you don't have the training in. That's unethical, right? So we're seeing a huge upskill across the province and internationally, and like I said, both in the public and private sector. So that's good. It means more resources for people out there. Yeah.
That's awesome news. but it's slow.
It's slow. I
Yeah.
know it's slow, which is why I like at least groups like this, or even some of the workbooks. Like, I think that even as a parent reading a book like this, like Jenny and Cameron's work is so awesome. And just learning about what's going on is so validating. And there's a lot of tips and strategies in there that are evidence-based, that can help you try to forge a path forward.
Yeah.
I know that some of our hospital programs, even if they can't take on a child, for example, a lot of them are willing to consult with pediatricians. So if you have a pediatrician and who's saying, I don't really know what I'm doing here, you know, there can be, you know, some collaboration with some of the other, like Sick Kids or McMaster. I know that sometimes they try to do as much as they can to help. Certainly my team and I and others, it's not just about us, but others try to offer some short-term support to parents. But Mallory, I really, you know, I just want to thank you so much. I feel like I could talk to you for hours about this. Is there anything else that you feel like you want to say? Did we miss anything major?
I don't think so. Not yet anyway. Maybe we'll have to do another one.
We'll do a part 2, right? We'll see. Yes. Yeah. Well, I'm so pleased. I'm so glad that we connected. I'm so glad you reached out to me.
Yes, and thank you for being so responsive. That was huge. I was shocked the day that you messaged me back. It was like, whoa, I wasn't expecting that. So,
well, I try because I know that most people are out there and there's just not enough. There's just not enough. And I'm so glad that I did. And I would love to have you back. I'd love to talk more with you about your journey and what you're learning as you and your family continue on. And I just, you know, send you all our support.
Thank you.
Yeah. And thanks to everybody who is with us today. Again, giant thank you to Mallory, and we'll see you next month. I believe we're going to do a webinar looking at eating disorders and what is healthy exercise. Ooh, I don't know. Another one that we'll have to talk about. Anyway, thanks, Mallory. Thanks, everybody. Have a good day.
Bye.
Bye.